Hello, everyone. My name is Oleksii, and as you heard, I'm working in IVF lab, and actually for the last 12 years, I'm doing test tube babies in a lab every day, all day long, basically. And today I'm going to share with you how we can actually use machine learning in our clinical practice and, to get the real-time medical decisions. And I hope by the end of this presentation, if you will just remember that you have to have kids as soon as possible. And there's a lot of opportunities for machine learning in our field of medicine, you should be fine. So I have nothing to disclose. I don't have any financial interests. Oops, sorry. And so I'm working for Reproductive Science Center. It's right here in East Bay. We are among the 30 largest IVF clinics in the US, and definitely among one of the best. We opened our doors for the patients 35 years ago, and as you may know, first IVF baby was born in England just in 1978, so 5 years right after we have first patients. And because we are large, we have a lot of data collect from the patient, and last year alone we have over 2,000 treatment cycles, and we've seen many thousand other patients. And just in definitions, what is infertility? Infertility basically is inability to have a child within 12 months. You would think why people need 12 months to have a baby, right? But usually it's 12 months, it's designed and basically defined by WHO. So if couple want to have a child, they should be successful within 12 months. And 84% of the couples will have a baby within this time frame. But unfortunately, there are going to be people who cannot get pregnant within 12 months, and it's actually a lot of people. If you would think in scale of United States, it's about 12 million people who cannot have a baby, in an old school way. So the bright side that half of them will be able to get the baby with new technology, which is in vitro fertilization, which we basically create embryos inside the lab, we analyze them, and then we'll transfer the best embryos. And right now, actually, this problem becomes bigger every year because people are actually know about this kind of treatment more, and because of I will tell you next slide, basically lifestyle and social changes. But because this treatment is kind of expensive, if you have just bare minimum, it's about $10,000, and it can go up $100,000, even more, if you have to use surrogate or other options. That's why the clinical decisions we make have to have very well thought, at least. So the biggest drivers of infertility here in the States, actually, it's aging of the population, because people delay having kids for the later, better times and have professional life. And also, I would say there's a lot of us become overweight because of the lifestyle. And the third, I call it celebrities and LGBTQs. It's basically how our society transforms and how we perceive the basically possibility of having children. Oops. And of course, we see all the celebrities who get kids when they are like 40 plus, and we think it's also possible. Yes, it's possible, but there's a lot of work behind it, and it's not so easy. It's just possible. So each of us basically have a biological clock inside our bodies, and as you can see, if we're talking about maximum fertility from the age of 25 to the age of 35, there's a huge drop, which basically we don't see it. We think if we're at 35, we are, just start our life. But from the infertility point of view, most of the fertile life is already gone. So most of our patients are about 35, 39. It's right here on the bottom. So you can see there is actually not much fertility left, and the time is crucial for them. So they have to have pregnant as soon as possible, because they will have to otherwise explore other options. And infertility treatment, IVF, what we do in lab in a clinic, idea is very simple. We would try to mimic all the processes from the human body in the lab, but because it sounds easy, but in reality, because we're trying to do the same stuff as nature, but in the lab, there's too many factors involved. We're talking about multidimensional process. We're talking about constant flow of the patients. We're talking about cutting-edge labor and equipment, and we're talking about hundreds of features who actually ultimately can affect our goal and result in a goal is pregnancy and a baby. So I personally think about it more like manufacturing right now, because we're talking about thousands of patients going through this, incubators, equipment, and it's kind of reminded me recent Kaggle competition when it was, you try to evaluate the process of constructing cars and testing the cars, because there's so many factors involved, and you never know which one is, crucial and how you can adjust your process. And there's like here on the bottom on the right, I put 10 factors can affect embryo development, but actually in our study we're analyzing hundreds of factors, and all of them can be crucial. So why we can do right now, why we cannot do it 10 years ago? So actually this graph is even surprising to me, because as you can see, the amount of data we collect in medical practices is increasing dramatically. Even 10 years ago, when I started doing this medical profession, we also have computers, but I don't know why it still was paper charts, and all the data was not easily accessible. But right now, every new device we get has some kind of internet connection and possibility to collect the data. And also the recent technologies we use, like morphokinetics and preimplantation genetic testing, they all heavily rely on machine learning. It's all basically algorithm and machines. And last point here is omics. I'm not going to talk about it a lot, but it just so you have an impression. In next few years, we're going to have data about what kind of proteins was around the embryo, what kind of DNA was around the embryo, what kind of media was around the embryo, and it's hundreds, if not thousands, different molecules, and all of them will be recorded and possible to analyze in future. And of course, how we do, how we extract the data. In all times, you just read the paper, but unfortunately, right now we have so many papers, it's no way we can follow all of them. We're talking about thousands of data, and unfortunately, most of the data is just small, case reports published by some groups, and randomized controlled trials are actually rare, and they are super expensive to do actually. And even if you look at the evidence we have in medicine, meta-analysis, which is the best quality evidence, it's pretty rare, and it's just a few papers published so far for any given problem. And it's just a regular paper with meta-analysis. You can see there's usually it's kind of like ensembling in machine learning. You took different predictions and look how they correlate with each other. But unfortunately, the sample size usually is small, and this have diverse conditions how they developed and being produced. So it's hard to analyze this data in meaningful way. So this, what kind of decisions we usually have to make during IVF cycle? First of all, we have to figure out who is this patient. So we need to figure out how much drugs we're going to use for this patient, how long we're going to use these drugs, what's the dosage, how long we're going to support this pregnancy, and then how many embryos we're going to transfer, 1, 2, or 3, right? So most of you would say transfer more to increase the chances of pregnancy, but you're aware about this octomom, and as soon as we transfer 2, there's chances of getting twins, and child death is 6 times higher when you have twins. So we have to actually do 1 embryo transfers, 1 embryo be transferred, and make its choice. And also, financial products, there's a lot of them. I'm not going to talk about them, but for the patient, because it's so expensive, they have to make a lot of decisions. How many cycles they have to pay for 1 cycle and get pregnant, or maybe they have to pay for 2 cycles, get discount. So it's basically risk sharing. But in the meantime, clinics, we have our data, we know our risks, but patients don't have this data to figure out what their risks are. And because we're talking about a lot of money, it can be crucial. So this is how we all look like long time ago. So the upper left corner, it's fertilized egg. You can see 2 circles. Basically, it's male and female DNA merging, create an embryo. On the top right, it's a 3 days old human being, which have around 8 cells. On the bottom left, it's embryo, which is 5 days old, which is about 150 cells. And to the right side, on the bottom, it's an embryo on day 6. And we can culture embryo in the lab only up till day 6. And then on day 6, they have choice of being transferred to the uterus, or being frozen, or being discarded. So our current level of technology is only up to day 6. And actually on this picture on the right corner at the bottom, actually this part is actually going to become a human being. Everything else is going to become extra-embryonic, placenta and all others around an embryo. So how we use machine learning? First and the most obvious example is time lapse. Because as I said, we have to increase the chances to get pregnant, we usually produce many embryos for every woman, for every IVF cycle, because it's expensive. So in every cycle, every patient would get around from 1 to 30 plus embryos. And then from these embryos, we have to select just one to transfer. And it's not easy because usually we have to make this crucial choice just based on information we have. So you see this, like, we have to pick up this winner and make it go. And all the way how we evaluate embryos is just you take embryos from the incubator, look at the embryos, make your notes, and look how they develop. So basically, in 5 days in lab, we can look at each embryo 5 times. But recently, with new technology, what they basically was done, the microscope was put inside the incubator. So now we don't have to even open the incubator to look at the embryo. And we have thousands of images 24/7. And of course, as soon as we get images, it's all digital, we can have computer vision to analyze these images. It was actually a breakthrough paper in Nature in 2008. So what they did here in Stanford, actually, they developed an algorithm who can look at the embryo, look at how it will be developing and cleaving the cells, and then based on these parameters, size, age of the patient, predict which embryo have bigger implantation potential. And of course, as soon as this published paper came out, it was a company who developed this algorithm, and right now it's available commercially. So this is EEVA. It's the same people from Stanford, and they designed the algorithm, took a lot of features, and basically they were able to prove that the way a machine can analyze this embryo is much better than a human being can, and specificity is much higher, and the probability of detecting which embryo will develop further to the blastocyst stage is much higher. And this product actually being used widely right now, especially in the countries where genetic testing is not permitted by law. And because we are right here in Bay Area, we were one of the first sites to help with them to develop this algorithm, and it was 2011. And of course, we published the paper back then, and this algorithm is still alive. They improved every day as long as they connect more data for this study. And also, because we have now computer vision, we can basically track individual cells and answer a lot of questions. And because sometimes one cell inside the embryo will divide not into 2, but into 3. And of course, the genetic materials will not be divided equally, so it creates a problem for the embryo. But if we would look, on just once a day, we would never figure out it was, from one cell. We would see just 3 cells and see, okay, so one cell divided by 2, and one didn't divide at all. So we also can implement this into the algorithm, design loss function, and punish our prediction based on this information. And here's the video I'm going to show you. It's right here. Safari. Okay. So this is how it's working in the real world. So here's the egg, right? On day 0, it gets fertilized, and this is how machine sees it. You see it become ellipsoid, booms, 2 cells. But unfortunately, because it's multidimensional in this microscope, we can take the picture in several dimensions. We can able to track up to 8 cells, and then it becomes too complex to track. But still, it's nice because we can track lineage and then make predictions based on this knowledge. So this product is commercially available, and Where's my presentation? Okay, notes. So if patients have a lot of embryos, it's basically done for every embryo, and then we can have predictions, with low and high implantation potential for every embryo. And if you look at the picture in the bottom right corner, you would never will be able to distinguish embryos by morphology, because by morphology they all look pretty similar. So this extra information that we got from machine learning is very beneficial. The next stage for us in the next method is preimplantation genetic testing. We use it a lot right now because it's super reliable, and because patients right now have not just genetically normal baby, they want to have boys instead of girls, In the future, they also will be able to choose between other features of the baby as well, but hopefully right now it's not possible. So why we have to test embryos genetically? Because, as we know, you probably don't know, but I'm going to share with you, the primary oocytes, it's what become egg, is formed before even baby born. So it's finished and done up to the age of 20 weeks of the baby. So this female on the left bottom corner has a baby, and the baby is 20 weeks old. And this baby has complete set of primary oocytes, no more until the end of the life of this baby. So what's happening if this baby, after the birth, will decide to have a baby, close to 40, it means this oocytes being in the body of this person for 40 years, which accumulates all the external radiation, all the stress we have, all the bad factors from outside. That's why if we have a baby at the age of 30, which means you already lost at least 16 years of, maybe 14 years of time when you can have a baby, right? So in many ways, people who are close to 40 will have embryos in a lab designed and developed, but then, even though most of them are going to have normal morphology, they're going to be genetically abnormal. They cannot implant, or if they implant, it's going to be miscarriage. So right now, what we do for this kind of patients, we will biopsy this embryos. So we'll take 4 or 5 cells, as you see, and do sequencing. And actually, sequencing itself is being done on this DNA float cells. It's basically a semiconductor with billions of wells, and every well will generate a signal, and then it's, of course, analyzed by machine learning and create sequence. And we can do right now this sequencing for every embryo because the cost is dropped dramatically. And as you can see, first genome cost was about $100 million, and right now we're down to $10,000. And recently, ba-bam, it's almost $1,000 or less. So I believe in the next few years we're going to have devices which you will be able to connect to the iPhone and sequence your genome, your baby's genome, your food, your beer, to make sure it's right size and right color, everything. It's going to be super cheap. But so far, as soon as we got information about every single embryo with the sequencing, we can do S&P analysis on them because each of us has a little bit different DNA. And by analyzing the signals with cumulative distribution function, we can basically say this embryo is normal or abnormal. We can say this abnormality comes from the mother or from the father. And also we can have not just our prediction based on embryos. We can track the single chromosome and say, you have 90% chances this chromosome is okay for this embryo. And then transfer the best embryo, not just morphologically wise, but also genetically wise. And as you see on this graph on the top left corner, because we screened embryos genetically, the live birth rate right now is flat line. So basically, as soon as we transfer genetically a normal embryo, the chance of getting pregnant is basically the same if you're 35 or 45. The only problem when you're 45, it's much harder to get this normal because if we will receive, 20 eggs, 99% of them is going to be abnormal. So it's hard to just get this one normal embryo. But as soon as we get it, it's fine. And then, if we know our pregnancy rates, we can build Kaplan-Meier curves and tell the patient, you have 60% chances to get pregnant with this one embryo, but if you have 2, you can have 2 transfers, and you have 70% chances. So it's like cumulative pregnancy rate. So patient can estimate how many cycles she should have, how many embryos she should collect, and if patient, close to end of the fertility, this patient can figure out how many embryos she's basically need to freeze if she wants to have 2 or more babies in the future. And of course, as soon as we got genetic data, we can do cluster analysis and based on this, select an embryo. But this is not being done in clinical practice yet. So of course, there's a solution for machine learning in IVF. And actually, this startup a couple weeks ago got $6 million. It's also from Stanford. What they actually do, they will take data from the patient, and then they will also get other data which is available on CDC or SART websites, and basically tell the patient, here's your chances to get pregnant. This is your chances to get with 1 embryo pregnant, with 2 embryos pregnant. So basically, they're trying to, based on the features of a particular patient and using their model developed, give patients some information to decision making. We are actually using in our electronic medical records this company called Telmatics. They are in New York, but essentially they do the same. They have data, they collect our data, they basically develop a machine learning model, and then it's a nice tool for the physicians to consult with the patient. So the patient will say, okay, I feel good, I'm fine, but we have to say, your chance of getting pregnant with timed intercourse is only 5%. If you do IUI, it's going to be 20%, and if you do IVF, which is complicated, but you're going to have 59%. And this data are going to be different for different IVF units because we all use kind of different equipment, different protocols, different experience. So that's why this model should be adjusted, and you have to have a lot of data to basically generate it more accurately. And another application of machine learning that we have, the same company, Telmatics, what they do, they try to develop the kit that basically will tell the patient what is level of fertility. So right now, out of 25,000 studies, they just choose 32 genes to analyze. So basically, it's pretty straightforward. Patient will get this tube delivered to their home. They will, collect the biological material, send it somewhere else, and then based on this analysis, they would say they can be proactive, and they will be told, you have this and this problem, so you should have babies right now, or you should choose this passive treatment, or you have to use donor X because you have this problem. So it's basically more information for the patient, and the patient will have hopefully better solution to deal with their problem. And as long as we have the best quality embryo, we might have it genetically normal, but the uterus itself is supposed to be receptive for the embryo. Because there is so-called implantation window, even the best quality embryo will not implant if we will miss this implantation window. And unfortunately, this window is never the same, not around day 14 or whatever it's on the cycle. It's basically always shifting. So what we can do biopsy for the patient. So we take some cells from the uterus and also run genetic analysis and analyze RNA to basically figure out when the uterus is going to be receptive. Of course, we're going to do unsupervised machine learning, and then we can figure out the genes that are involved and tell the patient you're supposed to have transfer in this particular date when your uterus, where your endometrium, going to be receptive. And this will help us to increase efficiency of the treatments, even to the next level. So all these advances in recent years actually help us to increase the number of patients when we transfer just 1 embryo from about less than 20% 7 years ago to almost 70% now. So basically right now most of our patients have just 1 embryo and they don't have to worry about having twins. And genetic testing right now is very common for our patients, and we do about 60% of all our patients right now with genetic testing. So I would say patients 35 plus year old, most of them are going to have genetic testing because right now it's very reliable, relatively cheap, and people like to see that they're going to have normal genetically embryos, and sometimes they have chance to choose sex of the baby also. And during the last few years we published a number of papers, but as we see these papers now, they all were basically about, you take factor A and look how this factor will affect live birth rate. And because we know now there's so many factors involved, it's no way, we can analyze this data in old-fashioned way. So our basically big idea is, what if we can analyze all available factors? So if we pull all the fields from our EMR and plug it into our model. And of course, it should be done with machine learning. So we designed a study when we divide all our factors into groups. It's all about 200 factors so far. And then we did, regular machine learning stuff like GLM, AirPart, GBM models. And actually, it was kind of interesting insight in our data. So because we can see what actually factors affecting our pregnancy rates, and because it's classification and regression tree, you can see some factors that I would never think is actually plays a crucial role in implantation and pregnancy. And also it's a good table to give information to our patients, because sometimes they have to make a decision which embryo to transfer also, because it's not only us in a clinic who will say, you're going to transfer this embryo, but they are actively involved. They also they have the final say always. And also we have to figure out which factors, clinical or lab factors, have bigger impact of the final outcome. So we can combine all these factors in one model and create our decisions. And of course, if we run a lot of trees, we can prioritize and figure out which one is the most important and pay our attention to these factors, or vice versa. There are several factors right now. We understand we were actually thinking about them, but based on our data, it doesn't make any difference to final outcome. And what the not so well about our data is that we have only poor predictions, poor predictors, weak predictors. The sample size is kind of small, about 10,000 patients so far. And accuracy is about 0.73. So, and of course we did Driverless AI. So far Driverless AI is one of my favorite tools. I know you probably know about Driverless AI more than I do at this point, but for us it just gives us benchmarks, so we know right after what is our minimum level we should agree to. Feature engineering designed by Dmitry is just awesome. There's many combinations of features I would never think, even though I have some domain knowledge. But then we can test these features. Feature importance also very visual, so we can give it to patient and physicians. And also we can, as I said, can figure out which features are not important at all, and we can convince our patient just to not pay attention to it. And then, which is good with this tool, we can plug different sets and patient subsets, so we don't have to basically clean our data, which is very beneficial for us, and get different predictions and discoveries. So as long as we get our data from the machine learning, we can test this data in old school way with logistic regression. And for example, for this table, we tested how morphology of the embryo will affect the live birth rate and clinical outcomes. So you see if we transfer AA embryo, which is the best quality, you get 61% live birth rate, and with poor quality, which is B minus minus B, 42%. But also this data can help us to tell the patient, because sometimes they say, I want to have a girl, but this girl is fair quality. But I have boy is a good quality, but I want to have a girl. So we can tell a patient, okay, you can have a girl as you want, but your chance is going to be this percentage point lower. And it's useful tool for us to give patient more information, so they will understand the risk and benefits what they're getting as long as we get more data. And of course, a lot of times we have to convince patients to transfer just one embryo, because they, sometimes it's very hard for them to come up with the money, and they want to be 100% sure to get pregnant. So when we transfer 2 embryos, the pregnancy rate is 71%, which is super high. And with one embryo, it's only 53%. But the twin rate, it's here on the bottom. Oh, sorry, this line's messed up. Twin rate is only 50%. 50% if you transfer 2 embryos. So basically, we can tell, okay, you're going to have better pregnancy rate, but it's almost 50% chances you're going to have twins, and then you have to deal with twins. Yeah, I know it's for people who have single baby. It's not, but believe me, 2 car seats and stuff, it's not easy. their special workflow had to be organized to basically to deal with 2 kids at the same time. So generally, the old-fashioned way of how we deal with in medicine, it's like we ask correct questions, we collect the publications, we appraise, we integrate, we evaluate. In the meantime, in my mind, we have to change publication to the data, because right now the time between new technology introduction and publishing something and use this data from publishing into real world too long for us. We can't afford it, so we have to have data to basically implement these decisions much faster, and we have to collect this data much faster. So it's all basically right now about the data. It's not about publications anymore. The only downside, as I said, is that every model designed will not be perfect. So it can work good for one place, but it can work not so well for other places. So I don't still have a clear idea how we're going to deal with this in the future. But I would say even having a model that works not so fine everywhere is better than not to have this model at all. So we definitely go in that direction. So my conclusion is that machine learning is not widely yet used in clinical practice, unfortunately, but we go in there because the data we get in with machine learning can enhance our experience, our knowledge, and provide better care for the patient. And AutoML, like Driverless AI, is a perfect example how this tool can be used by basically everyone and without any extra knowledge. And I hope in the future this kind of modules of Driverless AI will be embedded into the EMRs. So it's going to be basically decision-based. It's basically like Ask Siri, but in more sophisticated way. So thank you for your attention.
Thank you. So I think let's do some audience Q&A. Do we have another microphone for the audience? Over here? Oh, right here. Fabulous. Okay, Oleksii, that was fantastic.
Thank you.
Yeah.
Did I convince you?
You did. Okay, sweet. So I'll take this. If you have a question, just raise your hand right over here. For you.
So you mentioned you only have 10,000 data points to go with.
Yes.
Were you able to try to plug in any kind of novel attributes or features to try, like, how close does a person live close to a radiation plant, or something that?
No, we did not. Actually, we are part of a bigger network. We are part of Integramed, who has 1/4 of all IVF cycles in the United States. But the problem with selecting more data is, especially in healthcare, right? For us, it's HIPAA regulations. So it's Health Protection Information Act. It's a law. It's very hard to share this information because we have to get consent from the patient, and if we have thousands of patients. But we do have data about the patient, their zip codes, their addresses, and stuff like this. So we definitely probably can design a model and plug in some plans or whatever it is. It definitely can be beneficial. But this is probably going to be another study how somebody who is interested in this problem to develop. It's not going to help us to understand which factors involved in how to select the better embryo for the transfer, but it definitely may help to answer the question why patients have the problem they have. For some patients it's crucial. Yeah.
Any other questions? Anybody else? Oh, right here. All right. Bring this back to you.
I'm just wondering, obviously this can be a hot topic ethically. And have you found that with the data that you've had any ethical considerations or concerns that stopped you from using data in a certain kind of way?
Yes, actually there are a lot of data, I think in the future, especially with genetic testing, we will have a lot of data that, first of all, we will probably not disclose to the patient unless it's going to be actionable. Because, I believe in the future, in probably 5 to 10 years, right, we're going to create 20 embryos in the lab, and we're going to tell, this baby going to die at 40 years from prostate cancer, this baby will die from 50 years from something else, and patient will have to make also these choices because this information is available. And also, with the sequencing right now, because we have this information, patient may come after us later on and say, by the time you transfer, you said this embryo is normal by looking on the number of chromosomes, but you didn't tell us it's going to die at the age of 7 from some, real disease we don't test. But we have sequence. It's possible, probably going to be in future to analyze just based on sequence. there's a lot of ethical questions also based on how much power should give the patient to select, because in future they would say, I want to have a baby with blue eyes, whatever it is. I mean, right now what we do, not in our clinic, but in general in IVF field, there's possibility if, let's say, child have super rare blood disease and they cannot find a donor. So what they do, they will create a bunch of embryos, 40, let's say, embryos, and will implant only the embryo who can become a donor for already alive child to basically save your sibling. So I'm not sure how ethical this is, because on the one hand you will create a baby who will be a healthy, normal baby, but you create this baby for the purpose of saving the sibling. So it's right now technology of, especially in my field, is moving much faster than ethical concern and ethical consensus in the society. Right now, like all the sequencing stuff, time-lapse, imaging, didn't exist when I started 12 years ago in IVF lab. And especially with new technology like machine learning, when you would know, I'm not sure how we're gonna do it. We probably have to be disclosing the patient, because by the time patient will come to our doors, we will be able to know what's the pregnancy rate gonna be for this patient. So I will actually have to say to the patient, you're gonna pay this amount of money, but your chance is 12%. And patients say, oh, I'm not gonna do it. But we are as providers probably lose the business if we're going to tell them all the truth. So I believe we should be the government regulation who will force all professionals in the field disclose this information that's available, and let the people decide how to deal with this, and level the field for the patient and for providers as us. So there's too many actually ethical questions that arise. For us, a lot of many questions arise. For example, some people have good jobs and they don't want to carry the babies. They want to have surrogate just because they don't want to get pregnant and lose their body or their time. So fortunately, right now we can say we don't do like this. But there's all other places we can do it. I mean, there is legal and totally straightforward, but still. So it's just an example how technology can go ahead of the ethical questions, and in future we're going to have even more of them. So it's unavoidable. It's going to be conflict.
What about microfluidics? Do you use microfluidics?
We don't currently use microfluidics, but it's big promising feature for us in future, because right now we're able to put these embryos inside the incubator and put the microscope. But as long as you put this embryo inside the chip and also control the fluid of the embryo, you basically can control environment much better, have pictures of the environment. And actually it's going to be embryo on a chip, actually, because you put embryo in there and it's grow. And it's hard to say, but there's a lot of publications recently. It's possible to have, I didn't put the picture there, but it's just fascinating to grow embryo on the later stages inside the lab to provide all the nutrition and stuff. So I feel we're going to go to the directions when in a few years we will grow embryos from day 0 to the end.
Yeah, I'm part of the microfluidics research group.
Yes.
That's why I asked.
Yes.
Other one is SIRS. Are you using SIRS?
Which SIRS?
I thought you will know. SIRS is surface enhanced Raman spectroscopy.
No. No.
That has a high potential
To the stuff.
for precision, accuracy, etc., in.
Yeah, there is many fields because we use a lot of technology in IVF because I think it's because people who do this stuff professionally, they open to new technology because it was new when it was developed 30 years ago, and now it's new, and we attract and get in touch with many professionals in the field. So it's very cross science interaction.
Yeah.
And because all other fields are progress in tremendous speed, we can give the best features and try to implement for us.
And when you use SIRS, you can also, in addition to the embryonic fluid, you can also correlate sweat, saliva, urine, and many other body fluids and blood. And so you can do a correlation, which will be extremely useful for ML.
You see, we got not 200
Now,
features, we're going to have thousands of features in future. So we just have to figure out the way how to get use of it, how to make them work.
Yeah.
Cool. Any other questions over here?
So thank you for the talk. It was really cool. For the advice you give to patients, is there any like FDA involvement in what you can do, what you can say?
Say probably no. FDA, they control devices that we use, and they control also what actually it's legal or not legal, you know. But in terms of what we say, we just have to, you know, disclose all information we have. But sometimes, you know, if you don't have information, you don't disclose it. So, I mean, in legal terms, it can be probably willful blindness, but I don't know if it's, you know, enforceable or not in legal term, if I would say. So.
Do you correlate the there are a lot of people who take drugs, even doctors.
Yes.
Out of the 800,000 doctors in USA, 10% of the doctors, I'm not talking nurses, just the doctors are affected with the drug abuse.
Drug abuse.
Yeah. And so I want to see if that information is used or usable for correlation to see what time, when, because that affects the embryo.
Probably. I mean, we don't test for drug abuse our patients. We just, you know, recommend don't use even marijuana. But you know, it probably should be done, I believe. I actually believe that because we give the babies to the people, we kind of responsible what kind of people are going to get the baby. I know it's again another ethical question, but we actually recommend to have the psychiatric consultation before they go to the cycle, because it's a very stressful process, and you know, patients, especially if they, you know, live all their life without kids, and it's going to change their lives completely. Yeah. So and
based on the body fluid, my technology can say how much, what chemicals are there.
Probably, yeah. We're going to say, you're not going to give you a baby, right? Yes, but we generally should think what is the best for the baby, not for the patient, for us, like, because the patient have, you know, weird desires all the time, and they have different reasons to do what they do. But for us as medical professionals, we first of all should think about the baby. We should create the best baby we can, and make sure this baby will be at least healthy in the beginning. But I mean, ultimately, hopefully happy also, based on, you know, if we know who the parent's going to be. And also, I didn't say it during the presentation because it's kind of, you know, not belong to these topics, but unfortunately, California is one of those states where this kind of treatment is not covered by the government. So in many countries in the world, it's covered by the government, and actually in many states here in the US, it should be included in your basic health insurance. But here, you know, in California, we're like Wild West. So luckily, you know, IT companies like Facebook or Google, most of them will cover this for their employees, even more than needed. But we're talking about millions of people who don't have this kind of coverage, and IVF for them is the only choice to have a chance to have a baby. But unfortunately, because it's not covered by the government and not by the insurance, most of them will not be able to get a baby. And cost of adoption right now in the US, it's about $40,000+ also. So it's also, for many people, not even affordable.
Is this used in the animal husbandry?
IVF?
Yeah,
yes, definitely.
Human beings.
Actually, it's kind of interesting because we use a lot of knowledge from bovine IVF, because they do the same stuff for like years and generations. Yeah. And they actually more crazy than we are, because they can do, you know, with animals everything they, you know, can imagine with. But you know, even if you go to Whole Foods and you're gonna buy organic meat, these cows being created artificially. None of these cows can be produced natural way. They all being stimulated artificially. So it's all big farm and all big animals houses. They all right now IVF. All these animals created in vitro, because this is the most reliable way and most efficient way and the most cost-effective way. For good or for bad, you'll decide personally. But I actually was surprised, because I thought, you know, if you get organic from your store, it's organic in, you know, these features, but everything else is pretty straightforward science and created in the lab.
Even they say organic, it doesn't have to be 100% organic. Only a percentage can be organic, and they can say organic.
Yeah. Like, it's a total different topic for discussion. So right now we actually, we're at the age of using new technology, like creating embryos from 3 parents. So as we at some point can hit the floor. We have a patient who is 50, and we can't even get some eggs, not even to select this eggs for the. So what's going to be done? We're going to take the patient cell, take the DNA from the cell, and transfer the DNA to the eggs. And right now, it's already technology is available. It's done in several countries. It's already there. So patients who are even advanced age can have a baby if you are female. For the males, it's much better because spermatogenesis is 70 days brand new sperm. So it doesn't make any difference for us, for males. But for females, it's kind of crucial. So if they want to have their baby, they have to implement this advanced technology, which is right now super expensive, and just a few countries will let them do it because it's kind of controversial.
To use machine learning for medical purposes, are there any approvals that are needed? Or so say I had a bunch of medical data and I wanted to start my own company that use this to provide advice. What would be the process I'd have to
Actually, it's a good question because FDA struggles with this for years recently, and there is a lot of algorithms developed for the diabetes, for other stuff. I don't think they have manpower and brain and to analyze, because FDA, what they do, they just say, this device performs this way with this accuracy and with these features. But with machine learning, it's totally different because every time you plug new features and you develop your algorithm, so you basically, with machine learning, will have to retestify and retrain every time and get approval every time from FDA. So I think they will change something in their way of doing this stuff. I think because the way it is right now, you basically will create software. It's going to be approved by FDA, but you cannot sell this software and improve it to the patient. So every new version is supposed to be approved again with FDA, which is basically a nightmare.
What does that approval process take?
I don't know, it's years and millions of dollars.
Is it like something equivalent with like clinical trials?
It's not like clinical trials. I believe it's like you basically submit your data to FDA and they will review it based on what information you submitted to them. But still, it's very heavy process.
So in the lot of patients, they tried multiple IVF.
Yes.
Still, there is no success.
Yes.
So is there any way to make machine learning help them?
Yes, actually, one of the features we use in this machine learning, we use how many failed cycles they have, how many biochemical pregnancies they have, how many miscarriages they have, and actually this helps us to improve this model significantly. Because even though we have patients with normal embryo, with normal morphology, everything else, it doesn't work for some patients. And then, because we know our knowledge is very limited, we look at the fertility genes, it's 32 right now, but I believe it's thousands of them. And their interaction is very complicated, and we cannot, like 20% of all infertility cases right now, we cannot say what's wrong. We say it, we just don't know. And patient can try and maybe get pregnant, maybe not, but yes, there's many ways we cannot give the real reason. And if patient has a history on failed IVF cycles, it's definitely loss function. It definitely will decrease the chances for this patient because we know there's something we cannot control, something exists, but we just cannot fix it at this point. Yeah.
This infertility, is this dependent on race, which country they come from?
Yes, it's definitely age-dependent for females, first of all. It's age-dependent for males as well. Country-wise, I didn't look at the data, but yes, I feel there is.
There should be some difference.
Yeah, there should be some difference based on lifestyle, based on how healthy people are and stuff like this. And also, I feel like it's going to be different in different countries just because of level of medicine, how many patients get diagnosed. Because in many countries, patients don't get pregnant and go to the doctor. They just stay childless. And then, their rate of infertility can be lower because we still know they exist. So, but yes, because they're so multidimensional, I believe it would be different between different countries in even different regions.
If I understood you correctly, your lab works with your doctors.
So,
Do you work, the real question I have is, does your lab support other doctors in other clinics, or is?
So the way it's designed, actually, our lab is being owned by the doctors. We are the part of their practices. So we have here in Bay Area 4 offices. We have main location in San Ramon, whereas we have a lab and most of the physicians. But because physicians are basically main shareholders, they own the place and the lab is under their full control. So we have, and we had actually physicians from other practices who would come to us and use our technology, our equipment and stuff like this. But I believe recently we have just one physician left, and I don't think in future we're going to accept other physicians because it's kind of competitive right now, and we would rather have their patients than their physicians.
Okay, any other questions? We're back here, okay. Such great questions. Here you go.
I think to comment a little on the machine learning, or using machine learning on patients' data, I think there's HIPAA regulation on you can have access to patients' data only if you passed HIPAA training and if you're serving a patient this way. So if you just, my colleagues are doing something with patients' data and I'll ask them the data set and we'll play with it, I don't think it's HIPAA compliant.
We have to basically remove any, identification information from the patient. Yes, but
I'm just more answering to the previous question. And just a brief question. You mentioned that you're sequencing every embryo, and what's the gene panel? How many genes, and roughly what kind of things you can figure out from?
So basically, right now we have several kinds of genetic testing. First of all, there's patients who definitely need to have their embryos tested. For example, they are carrier of some genetic disease, and they want to, out of 20 embryos, select only those who will be normal. And for this patient, we basically have special labs who specialized in this kind of analysis. Most of the patients will go just to more general purpose genetic lab, and what they do is they actually run sequencing, but not very deep. So they won't make it cheap for the patient. So they basically will tell only what's the confidence of the chromosome level, so make sure they all have 46 chromosomes, but they will not give us information, nothing about their genes like in particular. So, and the patient, when they have to have special analysis, they will run sequencing more deeper and have better information about the particular embryos. And usually it's even sometimes genetic lab will require an extra time to prepare special primers, special probes to make it specific for this patient. But for us, most of our patients are just screening. So we know this patient is kind of advanced maternal age. So we know on the data this patient would need general screening. So we just separate embryos with normal number of chromosome and with abnormal number of chromosome. But we don't go deep inside and tell anything about the genes to the patient yet.
So heart genetic diseases are not covered yet?
Well,
heart, genetic diseases causing heart attacks and stuff like that are not covered yet?
No, we don't even say anything other than you have 46 chromosomes. Okay. It's basically to make it cheap for the patient, because even when we have to make it deep and big analysis, it's going to be just insanely expensive for the patient. And actually, there's not many genes right now that are actionable, so we can have different variant and difference between genes, but we cannot tell how significant from the medical standpoint it is, and how significant it's going to be in the future. So this is a good question because it's bioinformatics. There's a lot of people working on it, and we'll see. I mean, as far as you see, the cost of sequencing going to go down significantly, and I believe in the next few years we're all going to sequence our genomes, and machine learning scientists will going to try to figure it out what to do with all this huge amount of information.
You talked about twins and triplets.
Yes.
They will all be paternal twins, and they cannot be maternal twins.
So the twins we have, when we transfer 2 embryos, you have possibility of having 2 or 3 babies, because you can have monozygotic twins when one embryo will divide, and even when we transfer 1 embryo, there's about 1 to 3% chance it's going to be twins. So for us, when we transfer 2 embryos, most of the times 2 of them will implant. So, and we will have 2 babies. But there is a lot of medical complications with the twin pregnancy, because they try to steal food from each other, they try to damage each other, there's not enough space for inside for 2 babies. Most of the times they will not get to the term. So from a medical standpoint, it's a huge problem. And the cost for delivery for 1 baby is about $20,000 in hospital in regular, but for the twin pregnancy, it's easily up to $400,000 or $500,000. Yes.
But when you do the genetic test, because
Yes.
you are doing the genetic test also,
Yes. Not all patients, some patients. Yeah, most of the patients have
You
genetic
don't do.
test.
But you can do
Yes,
that. You have
yes.
the capability.
Yes, capable.
Does it mean that the two twins could have different genetic gene expression at the
Of course, I mean, they're totally different human beings. I mean, they have different genes. They're normal, but it's like brothers and sisters, you know. They just, it has to be, they were put in the uterus at the same time. Like we recently have a case when we had patient who have baby in 1992, I believe. And recently we saw the same embryo, siblings from this patient, and this patient donated this embryo for other couple, and another baby was born. So basically, on the paper, they were created at the same time, but in real life, they have over 20 years difference in age. So, and in our cryo storage right now, we have thousands of embryos, because a lot of people just, have them.
Yeah.
Big hand to Oleksii for doing some
You're
great
welcome.
work. It's one of the first actually one of the fewest new applications of driverless AI, feature engineering, automatic feature engineering. And we expect a lot more vertical, real application talks coming in the next few months, and a few meetups. We saw one from PayPal a few months ago. But we really thank him I saw, personally was seeing all the models he was building and the amount of work he's put in behind. Of course, feature engineering reduces a lot of the pain points in running the experiments repeatedly. But still, he was persistent in solving problems that are pertinent for the life.
Yeah, and for us also data preparation is awesome because we can just plug the data, don't think about data preparation at all. All these missing values, because medical data is it's messy because it's entered by so many people in different offices. So it's so nice for driverless AI. I can just plug it in and have my predictions. Yeah.
So the team, we actually have one of our chief architect has the twin problem you mentioned, where one of the child pulls off the resources and so on. So it's actually real problem that you're chasing that has implications for the world. So the team H2O actually came by my office and recommended we give you 1 year's license of the automatic feature engineering. And so you can continue to build models to save lives.
Awesome,
So
thank you.
congratulations.